Before we plunge into how to interpret ABG, let us go back to a bit of basics so that when we reach the actual ABG part, it will be easier to understand and interpret. So, as you all know, for a critically ill patient, the respiratory and metabolic processes that go on in the body are of utmost importance. Respiration doesn't mean just oxygenation, but it also includes CO2 elimination, and hence a good understanding of ventilation is an important aspect of understanding ABG. Similarly, the acid-base balance reflects the functioning of the metabolic processes in the body, and hence a basic understanding of these processes goes a long way in understanding how changes happen, how they are compensated, how they can be diagnosed, and how they can be treated. So you all know that the basic function of lungs is exchange of oxygen and carbon dioxide. Oxygen can be called the fuel for all of our metabolic processes at the cellular level, and lungs take up this oxygen from the atmosphere, while CO2 is a byproduct of the metabolic processes essential for life, and lungs do the job of throwing out the CO2. So, the atmospheric air contains oxygen. This oxygen then enters the respiratory tract via the oral and nasal routes through the pharynx, the larynx, and enters the trachea. The trachea then bifurcates into two main bronchi, which enter the lungs through the respective hyla and branch out into more branches, bronchioles, terminal bronchioles, and respiratory bronchioles. Now, alveoli are the ultimate unit where the exchange of gases takes place. Alveoli are surrounded by capillaries, which bring deoxygenated blood from the right ventricle through pulmonary artery, and these capillaries carry the oxygenated blood back to the left heart for circulation into the entire body via the pulmonary vein. The exchange of gases takes place across the alveolo-capillary membrane. The oxygen cascade refers to the progressive decrease in partial pressure of oxygen as it moves from the atmosphere through the lungs into the bloodstream and finally to the tissues, with the highest partial pressure in the inhaled air and the lowest in the mitochondria of cells, signifying a gradual decline in oxygen pressure as it travels through the body to reach where it's needed for cellular respiration. This decrease in pressure is what drives the diffusion of oxygen across the membranes at each stage. The pressure in the atmospheric air pressure of oxygen is around 159 mm of mercury. In the alveolar air, the air mixes with water vapor in the lungs, slightly decreasing the partial pressure of oxygen in the alveoli, typically around 100 mm of mercury. Then oxygen diffuses across the alveolar membrane into the blood, reaching a partial pressure of oxygen in the arterial blood around 95 mm of mercury. As the blood reaches the tissues, oxygen diffuses out of the capillaries and into the cells, further lowering the partial pressure of oxygen in the blood. The lowest partial pressure of oxygen is found within the mitochondria, where oxygen is utilized for cellular respiration, so it is generally about 1 to 3 mm of mercury. So the important factors that affect the oxygen cascade are ventilation rate, that is how effectively air is exchanged in the lungs, the cardiac output, that is the amount of blood pumped by the heart influencing oxygen delivery to the tissues, the hemoglobin saturation, that is the ability of red blood cells to bind oxygen and hence carry oxygen, and the tissue metabolic rate, that is the rate at which the cells consume oxygen. So, any disruption in this cascade at any level can lead to hypoxia. So, basically, hypoxia can occur due to reduced partial pressure of oxygen at any level. For example, at high altitude, the atmospheric pressure is low, leading to reduced PO2. Hypoxia can occur at the level of alveolo-capillary exchange if there is a disease of alveolo-capillary membrane. In the case of shock or because of lack of perfusion, there can be VQ mismatch, that is, ventilation perfusion mismatch, resulting in hypoxia. So, any disease process that reduces the oxygenated blood from reaching the tissues, or even an altered hemoglobin that has a reduced oxygen carrying capacity, can also cause hypoxia. And finally, if everything else is normal, but the tissue is unable to utilize the oxygen, it can lead to hypoxia. It is also important to understand the difference between hypoxia and hypoxemia. Hypoxia is reduced oxygen delivery to tissues due to any of the above reasons, but hypoxemia specifically refers to reduced oxygen content of the blood. So while understanding ABG, it is very important to understand the clinical scenario of the patient. Let us brush up our concept of respiratory failure. Respiratory failure is basically of two types, type 1 and type 2. Type 1 respiratory failure refers to a condition where the body is unable to adequately oxygenate the blood, resulting in low oxygen levels, hypoxemia, with normal or low carbon dioxide levels, while type 2 respiratory failure indicates a failure to remove carbon dioxide from the body, causing high carbon dioxide levels, that is hypercapnia, alongside low oxygen levels. So type 1 respiratory failure is because of any reason that leads to ventilation perfusion mismatch, and type 2 respiratory failure occurs basically because of alveolar hypoventilation. Now the causes for type 1 respiratory failure, which is due to VQ mismatch, can be different. So it can either be low ventilation and normal perfusion or low perfusion and normal ventilation. Examples of low ventilation normal perfusion are pulmonary edema, bronchoconstriction, while those for normal ventilation and low perfusion are pulmonary embolism, hypotension, shock, so anything which reduces the blood circulation, either local or generalized. The causes for type 2 respiratory failure are the causes of alveolar ventilation, causes of alveolar hypoventilation. So these can either be because of increased airway resistance, such as COPD, or reduced lung or chest wall compliance like pneumonia, rib fracture, obesity, or decreased respiratory muscle strength like GBS or motor neuron disease, or CNS depression caused due to drugs such as opiates. So, now that we have revised our basics of anatomy and physiology, let us proceed to the actual interpretation of ABG. So, let us begin. In an ABG, the first thing to see is the PaO2, or the partial pressure of oxygen in arterial blood. It should always be correlated with the oxygenation status of the patient. The normal PaO2 is more than 10 kilopascals, that is 75 millimeter of mercury on room air. It is usually 10 less than the FiO2 if the patient is on oxygen therapy. So if the FiO2 is say 40%, then the PaO2 should be 10 less, that is 30 kilopascals. The PaO2 to FiO2 ratio is also very important. Normally it is 400 to 500 millimeter of mercury. Less than 300 indicates mild respiratory failure, and less than 100 indicates severe. In terms of kilopascals, PaO2 less than 10 kilopascals indicates hypoxemia, while PaO2 of less than 8 kilopascals indicates hypoxemia and respiratory failure. Like we discussed before, type 1 respiratory failure, PaO2 is low and PaCO2 is normal. In type 2 respiratory failure, PaO2 is low and PaCO2 is high. So we should always see the PaO2 and correlate it with the oxygenation status of the patient. For example, if the patient has a normal PaO2 while on 15 liters of oxygen, it is abnormal. Similarly, a normal PaCO2 in a hypoxic asthmatic patient will indicate that the patient is not able to cope with the increased work of breathing. The next important thing to see is the PaCO2. The normal range is 4.5 to 6 kilopascals or 35 to 45 millimeter of mercury. PaCO2 is a key indicator of how well carbon dioxide is moving out of the body. An elevated PaCO2 level is often due to hypoventilation, while a decreased PaCO2 level is often due to hyperventilation. An elevated PaCO2 level more than 45 millimeter of mercury is called hypercapnia, and a decreased PaCO2 level of less than 35 millimeter of mercury is called hypocapnia. The next thing we see on an ABG is the pH. pH is the measurement of acidity or alkalinity of the blood sample based on the presence of H plus ions. Human blood normally has a pH in the range of 7.35 to 7.45. When the pH is less than 7.35, it is acidosis. When the pH is more than 7.45, it is alkalosis. To understand the concept of pH, it is important to understand this equation. Now here CO2 and water combine to form carbonic acid, and carbonic acid dissociates to form H plus ions and bicarbonate ions. So this equation shows that CO2 when dissolved in blood becomes an acid. The more CO2 added to blood, the more carbonic acid is produced, which dissociates to release free H plus ions. Second, it predicts that the blood pH depends not on the absolute amounts of CO2 or HCO3 present, but on the ratio of CO2 to HCO3. Thus, a change in CO2 will not lead to a change in pH if it is balanced by a change in bicarbonate that preserves the ratio and vice versa. Because CO2 is controlled by respiration and bicarbonate is controlled by renal excretion, this explains how compensation can prevent changes in the blood pH. So these are the normal values we see in ABG. PaO2 80 to 100 mm of mercury or 10.6 to 13.3 kilopascals, pH 7.4, that is 7.35 to 7.45, PaCO2 35 to 45 mm of mercury or 4.7 to 6 kilopascals, bicarbonate 22 to 26 milliequivalents per liter or 22 to 26 millimole per liter, and SaO2 more than 95%. Now, how is acid-base balance maintained? So there are two buffer responses, the respiratory buffer response and the renal buffer response. Respiratory buffer response, lungs are responsible for removing CO2. The PaCO2 in our blood is determined by the alveolar ventilation. So if the CO2 production is altered, we adjust our breathing to exhale more or less carbon dioxide as necessary to maintain the PaCO2 within normal limits. The bulk of acid produced by our body is in the form of CO2, so it is our lungs that excrete the vast majority of acid load. So activation of lungs to compensate for an imbalance starts within 1 to 3 minutes. The renal buffer response, the kidneys are responsible for excreting the metabolic acids. They secrete H plus ions in urine and reabsorb HCO3 from urine. HCO3 is a base and accepts H plus ions. So this compensation takes time because it is a renal buffer response. So there are basically two types of disturbances of acid-base balance, metabolic and respiratory. Metabolic primarily alter the HCO3 concentration in the blood. A decrease in serum bicarbonate level leads to metabolic acidosis. An increase in serum bicarbonate level leads to metabolic alkalosis. Respiratory. Respiratory processes alter the pH by changing the PaCO2 levels. So decreased ventilation leads to CO2 accumulation, leading to an acidic state through carbonic acid, leading to respiratory acidosis. Increased respiratory rate or tidal volume lead to body eliminating more CO2, leading to respiratory alkalosis. Now this chart shows the four primary acid-base disorders: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So as you can see, it is acidosis when the pH is low, alkalosis when the pH is high. It is respiratory when primary changes are in the PaCO2, and metabolic when primary changes occur in the bicarbonate levels. So in respiratory acidosis, the pH is low, PaCO2 is high. In respiratory alkalosis, pH is high, PaCO2 is low. In metabolic acidosis, pH is low, HCO3 is low. In metabolic alkalosis, pH is high, HCO3 is also high. We can see that in respiratory disorders, the change in PaCO2 is in the direction opposite to the change in pH, while in metabolic disorders, the change in bicarbonate is in the same direction as the change of pH. So it is a mnemonic to remember this: ROME, ROME, respiratory opposite, metabolic equal, for diagnosing the primary disorder. Now, what is compensation? So these are the physiological responses that work to keep the pH in normal range. So when PaCO2 is deranged, HCO3 is adjusted by kidneys. When HCO3 is deranged, PaCO2 is adjusted by ventilation. Respiratory compensation is faster than the metabolic compensation. Now let us come to the actual steps of ABG interpretation. Step number 1, as we discussed, check the PaO2. Determine the oxygenation status of the patient by clinically correlating the PaO2 with the FiO2 and determine whether the patient is hypoxemic. Step 2. Check the pH. Assess the pH to determine whether it is in the normal range of 7.35 to 7.45. If it is acidosis, if the pH is less than 7.35, alkalosis if pH is more than 7.45. The step third is to check the PaCO2 level. So check PaCO2 to determine whether the primary disorder is metabolic or respiratory. So compare the values of pH and PaCO2. If the change is in opposite direction, it is a respiratory disorder. If the change is in same direction, it is a metabolic disorder. So remember mnemonic tone. Next step is to confirm the bicarbonate levels. So assess the bicarbonate levels. In metabolic disorders, pH rises with increasing bicarbonate levels and decreases with decreasing bicarbonate levels. So the change is in the same direction. So again, to summarize, if pH and PaCO2 are moving in the opposite directions, the problem is primarily respiratory. If the pH and HCO3 are moving in the same directions, the problem is primarily metabolic. Now, fourth step is to look for compensation. So, every acid-base disorder elicits a compensatory response that limits the impact of the disorder on the pH. Compensatory responses operate by controlling the PaCO2-HCO3 ratio. The compensatory responses limit but do not prevent the change in pH, and compensatory changes occur in the same direction, obviously because they have to maintain the ratio. So this is the chart that shows the primary acid-base disorders and the associated compensatory changes. Now you can see here that the compensatory changes occur in the same direction. So for example, in respiratory acidosis, pH is reduced because it is an acidosis. The primary disturbance is increased PaCO2 because it is a respiratory acidosis, and the compensatory change is an increase in bicarbonate levels. So it is in the same direction as the change of PaCO2. Same with all the other disorders. It is important to know and understand how much compensation is expected in a given scenario, because sometimes there may be a mixed disorder in which the change in pH might not correlate with the expected compensation. So, this table shows us how to calculate the expected compensatory response. We will come back to the calculations once again. So, let us just quickly brush through the various acid-base disorders. Respiratory acidosis, where the pH is reduced and PaCO2 is increased, is due to reduced alveolar ventilation resulting in retained CO2. The causes can be airway obstruction, such as asthma, COPD, CNS depression from drugs like opiates or benzodiazepines, or stroke or raised ICP, neuromuscular impairment like GBS or myasthenia gravis, and reduced chest wall compliance or lung compliance like rib fractures. Respiratory alkalosis is where the pH is high and PaCO2 is low. It is because of increased CO2 washout leading because of hyperventilation. So the causes can be hypoxia, CNS stimulation such as fever, pain, anxiety, or tachypnea from diseases such as pulmonary edema, pleural effusion, pneumothorax, or pulmonary embolism. So in respiratory acid-base disorders, the compensation takes place in the kidneys. It involves reabsorption of bicarbonate ions into the proximal tubules. The response begins in 6 to 12 hours but takes days to develop fully. Hence, it is classified as acute, uncompensated, or chronic, compensated. In acute respiratory disorders, we can calculate the expected pH from the available values of PaCO2 in acute respiratory acidosis as well as acute respiratory alkalosis using these formulae. Similarly, in chronic respiratory disorders, that is acidosis and alkalosis, with the knowledge of the PaCO2 levels, we can calculate the expected pH. And thus, when we calculate the expected pH and the expected compensation, we can understand whether it is a primary disorder or there is a mixed disorder. In metabolic acid-base disorders, the compensatory response to metabolic acid-base disorders is an immediate change in minute ventilation that changes the arterial PaCO2 in the same direction as the primary change in the bicarbonate levels. So metabolic acidosis is the one where pH is reduced because of decreased bicarbonate levels. Now this can be because of increased acid ingestion, increased acid production, reduced acid excretion, or a loss of bicarbonate ions. Now, before we go into the detailed causes of metabolic acidosis, we need to understand the concept of anion gap. As you know, the serum should always have electrochemical balance. That is, the total number of cations or positive ions should be equal to the total number of anions or negative ions, so that the overall electrical charge is neutral. Routine tests do not measure all types of ions. The anion gap is representative of how many ions are not accounted for by lab measurements used in calculation. These unmeasured ions are usually anions, and hence the gap is called anion gap. And based on whether this anion gap is normal or high, metabolic acidosis is classified as normal anion gap metabolic acidosis or high anion gap metabolic acidosis. So how do you calculate the anion gap? So what our assumption is that the total number of anions and the total number of cations has to be equal. Now the anions and cations we know are usually sodium, potassium, chloride and bicarbonate. So thus we get the formula sodium plus potassium plus unmeasured cations is equal to chloride plus bicarbonate plus unmeasured anions. So which gives us the formula that unmeasured anions minus unmeasured cations is equal to sodium plus potassium minus chloride plus bicarbonate. The measure of relative This is the measure of relative abundance of the unmeasured anions. The usual anion gap, normal anion gap is 8 to 16 milliequivalent per liter, and so metabolic acidosis can be classified as normal anion gap metabolic acidosis or increased anion gap metabolic acidosis. So whether it is because of excess of unmeasured anions or not, that defines the cause of metabolic acidosis. So increased anion gap metabolic acidosis usually occurs because of addition of fixed non-volatile acid to the extracellular fluid, such as lactic acid, and normal anion gap metabolic acidosis occurs because of a net loss of bicarbonate ions. So increased anion gap metabolic acidosis can be because of unmeasured substances that cause acidosis, like lactate, toxins, ketones, and renal causes, while normal anion gap metabolic acidosis can be because of GI loss of HCO3, renal loss of HCO3, and renal tubular dysfunction. Now the increased anion gap acidosis, these are different causes, and the mnemonic to remember is mud piles. So M for metformin, methanol, U for uremia, D for DKA, P for propylene glycol, paracetamol, I for iron, isoniazid, L for lactic acidosis, E for ethylene glycol, ethanol, S for salicylates. And normal anion gap acidosis causes, the mnemonic is hard up, H, H plus excretion failure, hyperalimentation, hypoaldosteronism, A, acetozolamide, Addison's disease, R, renal tubular acidosis, D, diarrhea, excess stoma output, U, uterosigmoid fistula, P, pancreatic fistula. Then metabolic alkalosis is because of raised bicarbonate ions, resulting in raised pH. It can be because of overabundance of bicarbonate, either due to excessive loss of acid or excessive production of bicarbonate. Now, the causes of GI losses can be vomiting, nasogastric suctioning, or chloride-rich diarrhea. And renal losses can be because of diuretics, heart failure, nephrotic syndrome, Conn's syndrome, etc. Metabolic acidosis is characterized by primary decrease in the plasma HCO3 concentrations. The compensatory response is an increase in minute ventilation, resulting in reduced PaCO2. So, how to calculate the compensation for metabolic acidosis? The expected PaCO2 is given by this formula when we know the bicarbonate levels. Similarly, for metabolic alkalosis, which is characterized by the primary increase in plasma bicarbonate concentrations, the compensatory response is a decrease in minute ventilation, resulting in increased PaCO2. And in this way, we can calculate the expected PaCO2 from the values of bicarbonate. Then coming to another concept of base picture. So there is something called AHCO3 or actual bicarbonate and standard bicarbonate or SHCO3. AHCO3 is the actual measurement of bicarbonate in that actual blood sample. The problem with this measurement is that it is markedly affected by the PaCO2. If the PaCO2 is high, the AHCO3 is dragged higher and vice versa. What one would like to know is what the bicarbonate would have been had the PaCO2 been normal. It is this value that would provide a direct handle on what the metabolic system is doing, that is the SHCO3. So value of SHCO3 can be calculated if we have the values of AHCO3 and PaCO2. Now base excess measures all bases, not just bicarbonate. However, because bicarbonate is the greater part of the base buffer, for most practical interpretations, base excess provides essentially the same information as bicarbonate. The major advantage of base excess is that its normal range is really easy to remember. So one could probably have guessed that the expected value of base excess has to be 0. So it is somewhere between -3 to +3, the normal range. So a high base excess indicates higher than normal bicarbonate in blood. So either it is primary metabolic alkalosis or a compensatory respiratory acidosis. Low base excess is because of lower than normal bicarbonate in blood, which can be because of primary metabolic acidosis or a compensated respiratory alkalosis. So, if the pH and PaCO2 led to the conclusion that the problem was primarily metabolic, then the SHCO3 will do little more than confirm that. So SHCO3 will be high in alkalosis, low in acidosis. But if one has established that the problem is respiratory, then the base excess can tell us something about the duration of the problem. If, for example, in a respiratory acidosis, the SHCO3 has shown no sign of responding or base excess is normal, the probable explanation is that there has not yet been time to respond. That is, the problem is acute. Coming to gap-gap ratio, the gap-gap ratio is a calculation used to assess patients with high anion gap metabolic acidosis. It helps to determine if there are other processes occurring in the body, such as metabolic alkalosis or normal anion gap metabolic process. So in these patients, it is difficult to determine whether the high anion gap metabolic acidosis is the only process occurring or whether there is an additional process such as a normal anion gap metabolic process or a metabolic alkalosis which is contributing. So this is calculated by this formula, anion gap minus 12 divided by 24 minus HCO3. So this calculation essentially checks whether the change in anion gap from normal is equivalent to the change in bicarbonate from normal. That is, that all of the bicarbonate change is accounted for by a high anion gap process, or is there any additional process contributing to it. So if it is a normal anion gap, that is 1, it is a isolated high anion gap metabolic acidosis. If the not anion gap. If the gap is low, that is less than 1, there is a coexistent high anion gap and normal anion gap metabolic acidosis, and high gap, that is more than 1, there is a coexistent metabolic acidosis and metabolic alkalosis. The gap ratio is often used in diabetic ketoacidosis to determine whether an ongoing metabolic acidosis is due to ongoing ketoacidosis or it is due to the isotonic saline infusion in the resuscitatory period. So coming back to our ABG interpretation. So first thing we do is check the PaO2 and the whether patient has hypoxia. Then we identify the primary acid-base disorder. So if pH and PaCO2 are both abnormal, compare the directional change. Change in opposite direction indicates respiratory primary acid-base disorder, and change in same direction indicates that it is a metabolic primary acid-base disorder. So remember the mnemonic ROME: respiratory opposite, metabolic equal. So let us take one example. The pH is 7.23, PaCO2 is 23. What is the primary acid-base disorder? So pH is less, so it is an acidosis. PaCO2 is also less. It is not in the same direction as pH. So this is a primary metabolic acidosis because change in pH and PaCO2 is in the same direction, not opposite. The second step is to see if either pH or PaCO2 are normal. Then it indicates a mixed metabolic and respiratory acid-base disorder. If the pH is normal, the direction of change of PaCO2 identifies the respiratory disorder. If PaCO2 is normal, the direction of change in pH identifies the metabolic disorder. Now, when a primary respiratory disturbance and primary metabolic disturbance occur simultaneously, it is said to be a mixed acid-base disturbance. So if you see in the first picture, it is a fully compensated metabolic acidosis. So if these two processes oppose each other, The pattern will be similar to a compensated acid-base disturbance, and the resulting pH derangement will be minimized. So here interpretation cannot be made by measurement of pH alone, and we have to consider the respiratory and metabolic components individually. In the second image, which is a mixed respiratory and metabolic acidosis, by contrast, if these two processes cause the pH to move in the same direction, that is metabolic acidosis and respiratory acidosis, or metabolic alkalosis and respiratory alkalosis, a profound acidemia or alkalemia may result. So your pH will be exaggeratedly high or low, and a single derangement won't be able to explain the change in pH. So let us see example. So here pH is 7.37, PaCO2 is 55. So here pH is normal. Next we see the change in PaCO2. Now because the PaCO2 is high, it is a respiratory acidosis. But with respiratory acidosis, the pH should have been low, yet it is normal, which indicates that an additional mechanism that is raising the pH is present, which is metabolic alkalosis. So it is a mixed respiratory acidosis with metabolic alkalosis. So here we can see that the change in PaCO2 and HCO3 should have been in the same direction if it was compensation. But here the change in CO2 and HCO3 are in opposite directions, indicating a mixed disorder. So in mixed respiratory and metabolic acidosis, pH will be low, CO2 will be high, HCO3 will be low. While in mixed respiratory and alkalosis, respiratory and metabolic alkalosis, pH will be high, CO2 will be low, and HCO3 will be high. The next thing to do is evaluate compensatory responses for the primary acid-base disorder. For primary metabolic acid-base disorders, if the measured PaCO2 is more than predicted, it indicates an additional or secondary respiratory acidosis. If the measured PaCO2 is less than predicted, it indicates an additional or secondary respiratory alkalosis. For primary respiratory acidosis, if pH is less than expected pH for an acute condition, it indicates a secondary metabolic acidosis. If pH is more than expected pH for chronic condition, it indicates a secondary metabolic alkalosis. For primary respiratory alkalosis, if pH is more than expected pH for acute condition, it indicates secondary metabolic alkalosis. If pH is less than expected pH for chronic condition, it indicates secondary metabolic acidosis. If the measured pH is between the expected pH for acute, that is uncompensated, and chronic, uh, that is compensated, then it is a partially compensated respiratory acidosis or alkalosis. Chronic is compensated, not uncompensated. So let us take an example. So pH is 7.57, PaCO2 is 23. What is the primary acid-base disorder? So pH is high, which means alkalosis. PaCO2 is low, so it is a primary respiratory alkalosis. So what is the expected pH for this acute respiratory alkalosis? Let us calculate. So we calculate using the formula. Expected pH comes to around 7.54. So it is our pH is 7.57, which is higher than the expected pH, indicating that this is an acute respiratory alkalosis with secondary metabolic alkalosis. And the third thing that comes in ABG interpretation is to evaluate the metabolic acidosis with anion gap and gap gap. Now let us see some clinically interesting cases. Case 1. A 17-year-old female patient presents to A&E complaining of a tight feeling in their chest, shortness of breath, as well as some tingling in their fingers and around their mouth. They have no significant past medical history and are not on any regular medication. An ABG is performed on the patient while they are breathing room air, and the results are shown below. PaO2 107, pH 7.48, PaCO2 23, HCO3 23, and base excess +2. So let us go step by step. The oxygenation PaO2 of 107 millimeter of mercury on room air indicates no hypoxia. The pH is more than 7.35, indicating alkalosis. Now we have to see what the PaCO2 is. So PaCO2 is low and it is in the direction opposite to the change in pH. So it indicates a respiratory alkalosis. Now PaCO2 is low in keeping with the alkalosis. So respiratory component is contributing to alkalosis or is the entire cause of it. And now we see the change in bicarbonate. So since it is normal, there is no metabolic component. Base excess is normal, suggesting that there is no extra bicarbonate adding to the alkalosis. Compensation would involve much more significant reduction in HCO3. Here, bicarbonate is at the low end of normal, so it does not represent compensation. So, interpretation is respiratory alkalosis. Now, can you guess from the clinical scenario what can be the cause of this? So, a young female has presented with these symptoms such as tightness of chest, shortness of breath. She has no previous history, no comorbidities. So, the most likely diagnosis here is a panic attack, an acute attack of anxiety, possibly due to some stressful event like an upcoming exam, resulting in hyperventilation and washing out of CO2. The process being acute, the kidneys have not yet had the time to compensate for the same. Coming to case 2, you are asked to review a 62-year-old female who was admitted for shortness of breath. On your arrival, the patient appears drowsy and is on 10 liters oxygen by mask. You perform an ABG which reveals the following: PaO2 of 53 mm of mercury, pH 7.27, PaCO2 70, bicarbonate 25, and base excess +1. So, the oxygenation, a PaO2 of 53 mm of mercury on 10 liter of oxygen, indicates hypoxia. So, it is definitely a respiratory failure, but we don't know yet which type of respiratory failure she has. So, we see the pH. Now, pH is less than 7.35, which indicates acidosis. Now that we know there is acidosis, we have to check whether CO2 is responsible for the same. So PaCO2 is significantly high in the direction opposite to pH change, which indicates a respiratory cause. So in the context of low PaO2, a high PaCO2 suggests type 2 respiratory failure. The HCO3 is normal, so the metabolic system is neither contributing to the acidosis nor compensating it, suggesting that this is an acute derangement. The base excess is within normal limits as there has been no significant change in bicarbonate levels. So there is no compensation, and this is a case of acute respiratory acidosis due to type 2 respiratory failure. Coming to the next case, a 60-year-old female has been admitted to the acute medical ward of your hospital. On examination, she appears short of breath despite currently receiving 3 liters of oxygen via nasal cannulae. You take an arterial blood gas which reveals the following results: PaO2 69, pH 7.33, PaCO2 64.5, bicarbonate 29.5, and base excess of +4. Now the oxygenation, PaO2 of 69 mm of mercury on 3 liter of oxygen. 69 mm of mercury amounts to around 9.1 kilopascals. Now it is important to recognize that this PaO2 is much lower than you would expect for a patient on 3 liters of oxygen. An oxygen flow rate of 3 liter via nasal cannulae would be expected to deliver an inspired concentration, that is FiO2, of around 32%. And so you would expect that the PaO2 would be approximately 10 kilopascal less than this, that is around 22 kilopascals. However, she has a PaO2 of 9.1 kilopascals, which is grossly abnormal and indicates significant hypoxia, so suggesting a kind of respiratory failure. So pH is low, 7.35, so there is acidosis. PaCO2 is significantly high in the direction opposite to the pH change, so it is respiratory, suggesting a type 2 respiratory failure. The next step is to look at HCO3 and see if it is contributing to the acidosis. So raised HCO3 is compensating for the low pH. The base excess is raised in keeping with the excess bicarbonate, and there is compensation. Now let us calculate the compensation. In chronic respiratory acidosis, expected pH is given by this formula, which we can do by taking the value of PaCO2. So the expected pH we get is 7.3265. This is approximately equal to 7.33, which is our pH, and thus this is a compensated respiratory acidosis. This patient has COPD and has a chronically elevated level of CO2. As a result, the metabolic system has had time to compensate via the generation and retention of bicarbonate to oppose further decreases in pH. This explains why the pH is only slightly acidotic despite a significantly raised PaCO2. If this derangement in CO2 was acute, there would not have been time for a compensatory response from the metabolic system. So this is compensated and it is respiratory acidosis with metabolic compensation. Coming to case 4, a 21-year-old student has just returned from his observership in South Africa. In the last few days, he has developed severe diarrhea and has now presented to A&E. On assessment, he is very dehydrated and tachypnic. An ABG is performed and reveals the following: PaO2 110, pH 7.3, PaCO2 28, HCO3 12, and base excess -4. So the oxygenation PaO2 is 110 millimeter of mercury, which is high. It may be because of hyperventilation. pH is low, less than 7.35, so it is acidosis. Now we'll have to look at the PaCO2 to assess if this is contributing to the acidosis. So PaCO2 is low in the direction same as pH change, indicating that it is not the primary cause of the disorder. In fact, with this low CO2, we could expect an alkalosis. So we need to consider if this is an attempt by the respiratory system to compensate for metabolic acidosis. The next step is to look at the HCO3. So HCO3 is low in the direction same as pH change, indicating a metabolic cause. The base excess is low, again keeping with the metabolic acidosis. So now let us try to calculate the compensation. So for metabolic acidosis, the expected PaCO2 can be calculated using this formula, using the value of HCO3. So the result comes to around 26 plus or minus 2, which is the same as the PaCO2 we have seen. So thus it is compensated. So it is metabolic acidosis with respiratory compensation. So this patient is losing bicarbonate through the gastrointestinal tract as a result of diarrhea leading to metabolic acidosis. The respiratory system is attempting to compensate by blowing off carbon dioxide to create a respiratory alkalosis in an attempt to neutralize the acidosis and bring the pH back in the normal range. Coming to the next case, a 70-year-old man is admitted to A&E with central crushing chest pain. As the monitors were being attached, including a pulse oximeter, an NIBP, and ECG leads, he suddenly landed in a cardiac arrest. CPR was commenced immediately. After 5 minutes, he regained spontaneous circulation and began breathing again. The patient was put on 15 liters per minute oxygen and an ABG was ordered. It showed the following: PaO2 70, pH 7.15, PaCO2 61, HCO3 16, and base excess -9.9. The oxygenation PaO2 of 70 is very low with oxygen of 15 liter per minute. The pH is very low, 7.15. So the patient is certainly acidotic. We now need to look at the PaCO2s to see whether it is contributing. PaCO2 is high, direction opposite to the pH change, so it is the primary cause of the disorder. Bicarbonate is low, suggesting that the metabolic system is also contributing to the acidosis. Base excess is low, so interpretation is mixed respiratory and metabolic acidosis. Now this patient had a cardiac arrest, which meant that there was a period of impaired ventilation and end organ perfusion. This has ultimately led to hypercapnia, causing a respiratory acidosis in addition to the accumulation of products of anaerobic respiration as a result of hypoxia and reduced end organ perfusion, causing metabolic acidosis. Coming to the next and last case, a 32-year-old man presents to emergency department having been found collapsed by his girlfriend. An ABG was done which revealed the following: pH 7.25, PO2 of 84, PaCO2 24, bicarbonate 11, base excess -15, potassium 4.5, sodium 135, and chloride 100. So oxygenation PaO2 of 84 millimeter of mercury on room air is acceptable. pH is low, less than 7.35, so it is acidosis. PaCO2 is low, direction is same as pH change, so it is not respiratory. Bicarbonate is low, direction is same as pH change, so the primary disorder is metabolic. Base excess is very low. Let us calculate the anion gap from the given information. So the formula is sodium plus potassium minus chloride. So when we put the values, we get this number. So we know that the normal range is between 8 to 16. So this is definitely a high anion gap metabolic acidosis. Now, can you guess the cause of this metabolic acidosis? Try to remember the causes of high anion gap metabolic acidosis and correlate the clinical picture. A young man brought by his girlfriend. Was there a breakup? Did he drink too much? Or was it a proposal to which she said yes and they partied and he drank too much? So could you join the dots? Yes, it is most likely a case of ethanol poisoning leading to a high anion gap metabolic acidosis. So I hope my comprehensive lecture has cleared most of your basic concepts about ABG interpretation. If you have any queries, you can post them as comments and I will revert back to you. Like and subscribe to my channel to stay updated about all the lectures about anesthesia basics that I will be uploading in due course, and wishing you all the best. Thank you for listening.